Critical Care Medicine in 2009. His presentation today will be improving outcome in lung transplantation.
Yeah, that's right there. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the very nice introduction. And I thank the organizing committee for inviting me. So just, okay. Inshallah, today I'll give you a quick review about lung transplant, the history, the indication, the contraindication, and then go and talk about survival and have we done better over the last 3 decades, and hopefully, inshallah, conclude with our experience at King Faisal Hospital. Dr. James Hardy in 1963 was the first surgeon who done a lung transplant from Mississippi. He showed that it can be done. The patient survived for 18 days and later on died from renal failure and malnutrition. The medical society had to wait for 20 years until it was tried again in '81. That's when the first heart-lung transplant was done for primary pulmonary hypertension. Later on in '83, a single lung transplant was done for idiopathic pulmonary fibrosis. And then a double lung transplant was done for emphysema. After that, lung transplant, the volume started going up dramatically. And this is a graph from the Society of Heart-Lung Transplant. And you can see 2 things. One, it's going up, and we're doing more double lung transplant, and that's the purple bar, compared to the green, which is the single lung transplant. But still, the volume is still under 3,000, and we'll talk about that. And that's significantly because of the donor availability and suitability. About 85% of the lungs are rejected, and only 15% are used. What kind of surgeries? Depends on the disease and the severity of the disease. So the patient can get a single lung transplant, they can get a double lung transplant, and they can get a heart lung transplant. Indications, causes for end-stage lung disease are many. Most commonly is COPD, especially in the West. I'll show you our slides here in Saudi. We don't have as much COPD or COPD ending in lung transplant. Pulmonary fibrosis, cystic fibrosis, emphysema related to alpha antitrypsin deficiency, and other causes including sarcoid and histiocytosis X. This is a busy slide, but you can see this is from the society, again from the registry where they have 25,000. The most common indication was COPD, about 35%. After that, pulmonary fibrosis, and then cystic fibrosis. This is a pie chart showing you that the most indication for bilateral lung transplant is COPD and cystic fibrosis, especially for cystic fibrosis. It's really, you can't give a single lung to a cystic fibrosis patient because of the infection, because the new lung will be destroyed by the old lung. For single lung, again, COPD and IPF are common indications. Contraindication, and every single, and this is really none of them have been truly an absolute contraindication. Age, every year I read older patients are being transplanted, infections, pulmonary and extrapulmonary, but that's been also tested. I've recently read a report about MDR tuberculosis who underwent a double lung transplant and have survived 2 years. At King Faisal, we transplanted a patient with atypical Mycobacterium kansasi, and so far he's doing good. Significant dysfunction of other organs, and that's also, we've been pushing that. If you can get a lung liver transplant, you can give a lung heart transplant, and lung renal. And if there's any issues with the coronaries, you can stent them, or you can, the patient can undergo cabbage. HIV, there's reports from Italy that patients with HIV are getting transplanted, and also active Hep B and C. And social work, absence of social work is considered a contraindication. I was telling you about the age. This is from the registry again. You see about, our cutoff is usually 65 for single lung. But you see about 5% of the patients are older than 66, especially if their physiological age is younger than one stated. Quick slide about the allocation score. In 2005, the way we list patients in the transplant has changed. Now we take into consideration the urgency of the transplant and the benefit. So it's a score from 0 to 100, and the higher the score, meaning the higher the urgency and the greater potential for transplant benefit. This is a slide from one of my colleagues, a surgeon. It's a big surgery. If you do a double lung transplant, it's usually a clamshell incision, and you do it sequential. So you put the first lung, you use it, and then you put the second lung. But hopefully you can avoid bypass. Now we'll talk about the survival. So this is from the registry again, and you can see the half-life of the lung is about 5 years for double lung transplant. For all lungs. For double lung, it's about 6.5 years, and for single lung is about 4.5 years. And from the graph, you can see that in the first year, we lose about 20%. So at 1 year, only 80% of the patients are alive. And then about all these slopes, all these lines, the decline is progressive, and it's constant, and it's uninterrupted. So clearly there's a difference. There's something that happens in the first year, because we lose 2 out of 10. And then after the first year, it's a progressive loss of graft and patients. This slide shows you the causes that are leading to death in the patients. In the first 30 days, primary graft dysfunction is the leading cause. Right after that is infection, and that's in the first year. And after the first year, losing patient to chronic rejection or bronchiolitis obliterans is the leading cause. Primary graft dysfunction, that means you put the lung in and they just don't work. They don't oxygenate and they don't ventilate. The infection, it's a leading cause in the first year because our immunosuppression and our patients are heavily immunocompromised. We usually shoot for high FK levels, Celcept, and prednisone. So is it important for their patient to survive the first month and 1 year? Yes, this is the conditional, this is the Kaplan-Meier curves if the patient survived the first month. Remember I told you the numbers, they're about 5 years, but for cystic fibrosis, if they survive the first 3 months, their 5-year survival goes, their half-life of the lung goes to 7 years and 8 years. And these numbers are much, much better. So what happens post-operatively? The complications are very common. They're about 50 to 60%. The best thing we can do about them is you need an excellent ICU. You need to recognize first try and avoid them and hopefully prevent them. If they happen, diagnose them early and treatment, an appropriate treatment. And there are predisposing factors in the donor, recipient, in the surgery itself. It's a busy slide, and that's for a reason. Almost every system is affected post-transplant. You can get pulmonary complication, as I said, primary graft failure, but you can have sepsis, you can have phrenic nerve paralysis. Almost every organ can be affected post-transplant. This is an X-ray you don't want to see post-transplant. You put the lung in, and the patient developed graft failure. You're unable to oxygenate, and you're unable to ventilate. The lung should look blacker than this. This is a whiteout of the lung. And once this happened, the mortality is in the 60s and 70s. So we'll talk about primary graft dysfunction, which is the leading cause of death in the first month. The incidence is 25%. It's a leading cause of death. The mortality, depending on the severity of PGD, is up to 63%. We diagnose it based on X-ray and oxygen and gas exchange. And it's important to rule out things that could look like PGD because you can do something about them, hopefully. Cardiogenic shock, thrombosis of the left atrium, and hyperacute rejection. We manage it like ARDS, acute respiratory distress syndrome. We protect the lung. We give lower tidal volumes and lower peak and plateau pressures. You can use nitric oxide and Flolan to reduce the pressures. We ask our intensivists to keep the patient dry as much as possible. And you can use extracorporeal oxygenation if needed. And it does have an impact on long-term survival. Prevention, the way we handle organs have been different recently. There's a lot of research, clinical and basic, on how we handle donor lung. So we know that using colloid solutions is much better than crystalloid solution. Given prostacyclin, a vasodilator, improves the function of and reduces the incidence of PGD. Limiting ischemia time. We tell our surgeons not to fly very far away from Riyadh. We don't want the ischemia time to go beyond 8 hours. Flushing the lungs, antegrade and retrograde, have been shown. You can get a lot of clots out. And the cold temperature. We know hypothermia is good for organs. We tell our anesthesia to limit volume intraoperatively. And like I said, you cannot run a lung transplant team without having an excellent ICU care. A common thing that happens in the first year of transplant is acute cellular rejection. It's very common. It's a risk for chronic rejection. We diagnose it based on transbronchial biopsy. It could look like anything. If it happens, it's usually not a big deal. They respond very well to steroid. Most centers, and we do here at King Faisal, surveillance biopsy, whether it's been shown to improve survival, that yet to be determined. Infections are very common, and as I said, they're a leading cause after the first month. Pneumonia, viral CMV and non-CMV. With the prophylaxis, we're seeing less CMV, more bacterial and opportunistic, and the management is best with early diagnosis. And for our patients, we basically have a 24-hour service, 7 days a week, whether they're from Najran or Jazan. We keep very, very close follow-up with them. Because if they survive the first year, the numbers go dramatically up. I told you when I started that it's about, the half-life is 5 years. Now if they survive the first year, the half-life goes to 8 years, 9 years for cystic fibrosis, and 6.6 for COPD. So it's another good birthday for them. Busy slide, but after the first year, the leading cause is bronchiolitis, which is chronic rejection. So chronic rejection is usually progressive. Biopsy is usually not needed. We diagnose it based on spirometry. Once the patients start losing lung function, and it's important to rule other diagnoses that you can do something about. And the pathology of it is bronchiolitis obliterans. You're supposed to see an airway here, but I don't see it. It's completely occluded by the disease, and it's considered an airway rejection. What are the risk factors for bronchiolitis obliterans? CMV pneumonitis, reflux, episodes of acute rejection, non-compliance of the medication, and lymphocytic bronchitis. There's a lot of literature and papers, but there are mostly retrospective analyses and studies. Only, I think one is prospective, which is the one that was published from Pittsburgh, Aldo-Iacono and Griffith, about inhaled cyclosporin. But none of those have been truly groundbreaking for the treatment of bronchiolitis obliterans. But steroids have been tried, inhaled cyclo. I know that they're doing another study now sponsored by NIH, photopheresis, rapamune, azithromycin. And if everything fails, you can try a retransplantation, but that's an ethical question. Do you give a lung to somebody who already had a lung while you have patients dying on the waiting list? So have we done better over the last 3 decades? Yes. If you had a transplant in 2000 to 2008, you're much better than, your survival is significantly better than if you had it in the 80s to 90s. And that's because things have changed. We practice medicine differently, ICU is going better, and our immunosuppressions are different. One, this is us in this era, we use more induction. We give targeted induction than polyclonal. So that's different than before. We use FK, we replace it from cyclo. Also we replaced Imuran with Celcept. So these could be causes. Other possible causes, again, almost every center has very aggressive follow-up. And these are possible. Nothing has been proven that improves survival. CMV prophylaxis, the drugs are much better. We give Valsite, better bioavailability. And we give, more studies are saying longer duration of CMV prophylaxis are better. Fungal prophylaxis, some centers use universal prophylaxis. And PGD management, I showed you the slides about taking care of the donor. And for acute respiratory distress syndrome, the mortalities have improved. And I told you we manage PGD as ARDS. So our ventilators gotten better, intensivists are not inflating the lung and injuring the lung much as before. And we do double lung more than single lung. Who does well with lung transplant? The young. If the patient is younger, which makes sense, they do much better than the older patient, especially the group of 30s and the 40s. CF, they also do the best compared to pulmonary fibrosis and primary pulmonary hypertension. There are no difference between male and female if they undergo transplant. What are the risks for mortality? The age, as I told you, especially if they cross 55, the surgery becomes riskier compared to the young. The center volume, and I share this with all our patients, the more the transplant center does, the better the outcome, especially if they cross 25. The sicker they are, if they're requiring more oxygen, or the sicker their heart, the worse their outcome. I'm going to skip those slides. So what are the morbidities we see with lung transplant? Hypertension and renal dysfunction are very, very common, and they start in the first year, and that's because of probably the immunosuppressions we give. So they truly need very close follow-up post-transplant. Hypertension, for their longer survival, is almost 100%, and renal dysfunction is about 40%. So after I scared you about lung transplant, this slide tells you that if the lung works, it really works. This is their functional status of surviving patients. About 80% have absolutely no activity limitation post-transplant. And this is sustainable even in the 10 years post-transplant. So if it works, it really works. What are the challenges we have? Again, our volume, in 2009, only 3,000 are reported surgeries are done. And the biggest reason is donor limitation and suitability. And the case even stronger here, unfortunately, in the kingdom. We decline about 85%. Usually once we get the call, the patient is already indicated for about 10 days. They're growing Acinetobacter, their oxygenations are bad. So usually we decline the lungs. So what Scott does is very, very important to what we do. Primary graft dysfunction, I told you we still lose a lot of patients, so we need to improve on that. And the treatment of bronchiolitis obliterans. The group in Toronto in 2010 published their experience with an ex vivo machine. Once they get the call, they take the lung and they put it on this machine with an acellular perfusion, and they improve the oxygenation for 4 hours. And if it does, they use the lung. It's promising, but there's a lot of criticism of that study because one of their arms they used, the oxygenation wasn't actually that bad. But I think it's promising and remains to be determined, inshallah. So the last few slides, I'll talk about transplant in Saudi. So the cases that I've reviewed in King Faisal Hospital, because most of the follow-ups, patients, even if they get it outside, they come and follow up with us. The most common indication is actually bronchiectasis. I remember in the US, I would go 4 months before I see a single case of bronchiectasis. Now in my general pulmonary practice, almost every other patient is bronchiectasis. And I'm talking about non-CF bronchiectasis. And then pulmonary fibrosis is also common. And I don't see COPD here. I told you the most common from the registry is COPD, leading into respiratory failure and lung transplant. And I know there are smokers in Saudi, but for some reason, they're not requiring lung transplant. This is our program in Saudi. The hospital have been doing it for years, but we have not been doing it consistently. Over the last year and a half, we've done 18 lung transplant, which is very good. And the survivals are comparable with the society. We're far from perfect. We need to keep working, and we need to keep doing it. But the biggest limiting factor, because our patients need it, is donor availability and suitability. So all the support goes to Scott. This is a girl, Roseanne. She's very nice. I got called about her a year ago. A physician told me that she's end stage because of BO and bronchiectasis. And she needs a transplant. She told me when I read her report, her BMI or her weight was 27 kilos. So I declined. So she called me again and she said, you got to see the girl. She's very smart. She's usually the first in her class. So I said, fine, bring her to the hospital. So we bring her, and she's a very bright kid, and unfortunately there are many, many like her. And I invite the surgeons, they see her and they do the transplant. And this is the outcome we hopefully to see. Her father called me yesterday, I was checking on her, and he said she's playing soccer, she's growing, and again, she's one of those 80% with absolutely no functional limitations. Thank you.
Shukran, Dr. Eid. The next speaker is Dr. Imran Ilyas. Dr. Imran completed his medical degree at the Punjab University. His FRCS from London in 1992 and his MCH orthopedic in 1996. Since 2003, he has been consultant orthopedic surgeon and director of the bone bank at King Faisal Specialist Hospital in Riyadh. Dr. Imran's talk today is the King Faisal Hospital bone bank experience and update in bone and tissue banking.